Namaskar, this is Dr. Deptee Warikoo, Department of Physiotherapy, Dolphin PG Institute of Biomedical and Natural Sciences. Our today's lecture is on airway clearance and chest mobility. In these lectures, we will be dealing with the exercises which are used to increase the chest mobility and the airway clearance techniques. So first, we will be focusing about the chest mobility. Chest mobilization exercises are any exercises that combine active movements of the trunk or extremity with deep breathing. They are mainly designed to maintain and improve mobility of the chest wall, trunk, and shoulder girdles when it affects ventilation or postural alignment. For example, a patient with hypomobility of the trunk muscles on one side of the body does not expand the part of the chest fully during inspiration. Exercises that combine stretching of these muscles with deep breathing improves ventilation on the both sides of the chest. Chest mobilization exercises are also used to reinforce or emphasize the depth of inspiration or controlled expiration. For example, by leaning forward at the hips or flexing the spine, or as he or she breathes out, this pushes the viscera superiorly into the diaphragm. Now, let's see what are the specific techniques. So, first technique we will see is to mobilize one side of the chest. While sitting, have the patient bend away from the tight side to the lengthen hypomobile structures and expand that side of the chest during the patient inspires. Then, have the patient push the fist hand into the lateral aspect of the chest, bend towards the tight side, and breathe out. Progress by having the patient raise the arm overhead on the tight side of the chest and side bend away from the tight side. Here you can see the chest mobilization during inspiration and expiration. This is used to mobilize the lateral rib cage. Next is to mobilize the upper chest and stretch the pectoralis muscles. While the patient is in sitting position in a chair with hands clasped behind the head, have him or her horizontally adduct the arm during the inspiration. Then instruct him or her to bring the elbows together and bend forward during expiration. Like this, the butterfly breathing we call it. Next, to mobilize the upper chest and shoulders, while sitting in a chair, have the patient reach with both the arms overhead during inspiration and then bend forward at hips and reach to the floor during expiration, like this. You can see the chest expansion is increased with bilateral movements of the arms overhead during inspiration, and then during expiration is reinforced by reaching the arms towards the floor. So these are the techniques for chest mobility. Next, we will see the techniques for airway clearance. For airway clearance, what techniques we'll be seeing are basically the two techniques, the ACBT and autogenic drainage. First technique, what we will see will be the ACBT technique, that is active cycle of breathing technique. So, the active cycle of breathing technique is used to mobilize and clear excessive bronchial secretions. This is an active breathing technique performed by the patient and can be used to mobilize and clear excessive pulmonary secretions and to generally improve the lung function. It has been shown to be effective for increasing the lung function, and it also neither causes any increase in hypoxemia nor increases the airflow obstruction. It is a cycle of breathing control, thoracic expansion exercises, and forced expiration techniques combined together. Now, what are the uses of these techniques? First, it loosens and clears the secretions from the lungs. It improves the ventilation in the lungs. It improves the effectiveness of your cough. So, ACBT consists of mainly three main phases. First is the breathing control. Second is the deep breathing exercises or thoracic expansion exercises. And third is the huff or forced expiratory techniques. Additionally, a manual technique or positive pressure can be added if and when indicated. A randomized control trial showed positive effects of active cycle breathing technique along with routine chest physiotherapy on arterial oxygenation, heart rate, pain perception following coronary artery bypass surgeries. So we can say that yes, it is an effective technique. It may include percussion and expiratory vibrations at the end of the technique. So, this is the cycle, the active cycle, which starts with 20 to 30 seconds of breath control, then 3 to 4 deep breaths, then again breath control, then 3 to 4 deep breaths, then again breath control, followed by huffing and then breathing. This is a cycle which is performed in this. So, first thing is the breathing control. It is used to relax the airways and relieve the symptoms of wheezing and tightness, which normally occur after coughing or breathlessness. So, here we encourage the patient to close their eyes while performing breathing control. This can also be beneficial in helping to promote relaxation. It is very important to use breathing control in between the more active exercises of ACBT as it allows for relaxation of airways. Breathing control can also help when one is experiencing shortness of breath, fear, signs of bronchospasm, anxiety, or is feeling somewhat of panic. Now, what instructions we have to give to patient while performing the technique? First, patient has to be said to breathe in and out gently throughout your nose if you can. If you cannot breathe through your mouth, instead. If you breathe out through your mouth, it's best to use breathing control with pursed lip breathing, which we have already discussed in earlier classes. Try to let go of any tension in your body with each breath out and keep your shoulders continuously relaxed. Gradually try to make the breath slower. Try to close your eyes to help you to focus on your breathing and to relax. Breathing control should continue until the person feels ready to progress to the other stage in the cycle. The next stage is the thoracic expansion exercises, where deep breathing exercises included in this. Thoracic expansion exercises are deep breathing exercises emphasizing on inspiration. Inspiration is active and may be combined with 3-second hold before the passive relaxed expiration. The post operative maneuver of a 3-second hold at full inspiration has been said to decrease the collapse of lung tissue. The effectiveness of this thoracic expansion exercises in re expanding the lung tissue and in mobilizing and clearing excessive bronchial secretions can also be explained by the phenomena of interdependence, which we have already read in physiology. This is the effect of the expanding forces exerted between the adjacent alveoli. At high lung volumes, the expanding forces between the alveoli are greater than at tidal volume and assists in re-expansion of the lung tissue. 3 or 4 expansion exercises are usually appropriate. Thoracic expansion exercises can be encouraged with the help of PNF also. The therapist can use PNF over the part of the chest along with the thoracic expansion exercises. Sometimes an additional increase in lung volume can be achieved with a sniff maneuver, but it has to be done at the end of the deep inspiration. Now, what are the instructions which we generally give to the patients while performing these thoracic expansion exercises? First, we have to tell the patient to try to keep your chest and shoulders relaxed. Then, take a long, slow, and deep breath in through nose if you can. At the end of the breath, hold the air in your lungs for 2 to 3 seconds before you breathe out. Breathe out gently and relax like a sigh. No forced expiration is instructed. Repeat 3 to 5 times. If the patient feels lightheaded, then it is important that they revert back to the breathing control phase of the cycle, the first phase. To facilitate a maximal inspiration, proprioceptive feedback with the therapist or patient placing the hands on the thoracic cage can be beneficial. Then, thoracic expansion exercises may be combined with chest shaking, vibrations, clapping, which we have already done in our previous sessions. These techniques may further assist in clearance of the secretions. After thoracic expansion, the third phase comes, which is the forced expiration technique or FET. The forced expiration technique is a combination of one or two forced expirations, which we call as huffs, and periods of breathing control in between. Huffing to low lung volumes will move the more peripheral situated secretions, and when secretions have reached the larger ones, that is the proximal upper airways, a huff or cough from a high lung volume can be used to clear off the secretions. As lung volume decreases during forced expiration maneuver, the equal pressure points move more peripherally. And below functional residual capacity, they move towards the alveoli. The high flow of a forced expiration maneuver would also be expected to aid the mucus clearance and the expectoration of the sputum. So you will have proper lung clearance along with it. A huff from mid-lung volume is more efficient and probably more effective. A huff from mid-lung volume, a medium-sized breath should be taken in, and with the mouth and glottis open, the air is squeezed out using the chest wall and abdominal muscles. So this is the basic technique which we perform, the huffing. It loosens the secretions from periphery situated airways, and then it is easy to take the secretions out. When the secretions have reached the upper airways, a shorter huff is very useful. A peak flow mouthpiece or tubing may improve the effectiveness of huff as it helps to keep the glottis open. As essential part of the forced expiration technique is the pause for breathing control after one or two huffs. It prevents any increase in the airflow obstruction. So we have to do it properly. Before that, we should know we can have two types of huffs, a medium volume huff and a high volume huff. The medium volume huff is when which helps to move secretions that are lower down in your airways. Here we take a normal size breath in and then an active long breath out until your lungs feel quite empty. Okay, then high volume huff. This helps to move secretions in your upper airways. Here we take a deep breath in, open your mouth wide and huff quickly. They are performed only 1 to 2 huffs together, as repeatedly huffing may make your chest more tight. So this is the basic cycle of ACBT, where we start with the breathing control, that is relaxed breathing. Then we take 3 to 5 deep breaths for thoracic expansion. Then there is forceful expiratory techniques, the huffing. And then at last, either the hard huff or the coughing to cough out the secretions. So what are the indications of ACBT? You can perform ACBT post-surgical patients, like patients like chronic diseases like cystic fibrosis, bronchitis, acute increased sputum production, if there is poor expansion of the chest, if there is retention of the sputum, if there is cystic fibrosis, bronchiectasis, atelectasis, or there are respiratory muscle weakness, patient is on mechanical ventilation, suffering from asthma, or audible rattling in airways, palpable secretions are there. In all these cases, ACBT has found to be effective. Now, what are the precautions which we have to take care in ACBT techniques? It is important to constantly assess for dizziness or increase of the shortness of breath. If the patient is feeling any dizziness or having decreased the number of deep breaths taken during the cycle, return back to the breathing control phase. If patient is having inadequate pain control, or he is suffering from some bronchospasm, or there is acute unstable head, neck or spinal injuries, in those cases we have to avoid using ACBT techniques. There are few contraindications like patients not spontaneously breathing, unconscious patients, patients who are unable to follow instructions, or sometimes agitated or confused patients may also be a big contraindication to perform these techniques. Sometimes we use these vibration techniques along with ACBT. So this was about the ACBT. the first airway clearance technique. The second technique which we will be dealing today is the autogenic drainage technique. The autogenic drainage technique is an airway clearance technique which utilizes controlled breathing at different lung volumes to loosen, mobilize, and move the secretions in three stages towards the larger airways. So, we need to know that we are trying to move the secretions from lower airways to larger airways. Autogenic drainage is based on a series of physiological principles believed to enable the patient to achieve an independent airway clearance regime that is adapted to their individual pathology and pulmonary function. A breathing technique designed to milk or squeeze air out of the lungs. Autogenic drainage was developed in Belgium in the late 1960s by Chevalier. The overall aim of AD is to reach the highest possible expiratory airflow in different generations of bronchi, simultaneously with an active but not forced expiration. Secretions are systematically transported from peripheral to more central airways by breathing at lower lung volumes in the expiratory reserve volume through progressive higher lung volumes in the inspiratory reserve volume. It uses breathing at different lung volumes, which loosens first the secretions, then mobilizes the secretions, and then moves the secretions to larger central pathways. It is very important that we know that what type of techniques we are basically using in these techniques. So it consists mainly severe steps in autogenic drainages. So it composed of three breathing phases. The first phase is patient breathes in normally but exhales each breath close to respiratory volume. Second is patient breathes in slightly above normal uh, respiratory volume but exhales normally. And third is the patient breathes in close to vital capacity but exhales normally. So all three phases are repeated as necessary. So phase 1 we call it as unstick secretions. So patient breathes as much air out of your chest as you can and then take a small breath in using your tummy. Then feeling your breath at the bottom of your chest, you may hear secretions start to crackle or they start to resist and desire to, if you feel a desire of cough. This loosens the peripheral secretions by breathing at low lung volumes. We can repeat for at least 3 breaths a time. Then there is phase 2, that is the collect of secretions. As the crackle of secretion starts to get louder, change to medium sized breaths in. Feel the breath more in the middle of your chest. Repeat for at least 3 breaths. This collects the secretions from central airways by breathing at low to middle lung volumes. Then we have phase 3. It is the evacuate secretion phase. When the crackles are louder still, take long, slow, full breath in to your absolute maximum capacity. Repeat for at least 3 breaths. Expelling secretions from the central airways by breathing at mid to high lung volumes. It is very important for evacuating the secretions. Here you can see the 3 stages. The initial stage, the second stage and the third stage. This initial stage, low volume breaths to mobilize secretions from the periphery airways. Then the stage 2, medium, that is near the tidal volume breaths to control mucus from the mid airways. And stage 3, the larger volume breaths, which enable expectoration of the cough from central airways. Now, what are the benefits of autogenic drainage? Here, no equipment is required for drainage of the cough and the secretions. It is very beneficial thing. Then patients can perform their airway clearance independently. And less effort is required to expectorate, which reduces stress on the pelvic floor as well. It is very good and important for the patient. Then, what are the disadvantages? Patients generally need to be over 8 years old. The technique can be difficult to teach to patients. Patients need the cognitive ability to understand the basic physiology behind the technique. To benefit from auditory feedback, patients need to have a moderate or large amount of sputum, which sometimes becomes difficult. So, how we will perform this technique? So, first, we'll tell the patient to clear your nose and throat by blowing your nose and huffing. Then slowly breathe in through the nose to keep the upper airways open. First, take a large breath in, hold it for a moment, and then take a small breath in, and then relaxed breath out. Breath out through the mouth, keep the airways open. At low lung volumes, as we know, the abdominal muscles, we are using our abdominal muscles. To hear the mucus rattling in the airways when breathing the right way, put a hand on your upper chest and feel the mucus vibrating. High frequency means the mucus is in small airways. Low frequencies means that the mucus is in the larger airways. Using this feedback, let you easily adjust to the technique. Then repeat the cycle. You will see there is crackling of mucus and then breaking of mucus, and then you will see that the mucus is coming out. We can do these autogenic drainage techniques in conjunction with other airway clearance devices like PEEP. Traditionally, it is combined with PEEP via pursed lip breathing to assist the patient in balancing expiratory force during autogenic drainage or flow modulation. It increases levels of PEEP. If we want to increase the levels of PEEP, we have to modulate like some devices like PEEP mask or flutter, etc. So, this is about autogenic drainage. We can have it in patients like cystic fibrosis, chronic bronchitis, pneumonia, bronchiectasis, and chronic obstructive pulmonary diseases. So, this was about ACBT and autogenic drainage. I hope you understood it. If there are any queries or questions, you can ask them. Thank you so much.